Jerry,
Here.
and Kevin.
Here.
Great. So tonight, after we review the minutes and do public comment, if there is any, we're going to get a update on the needs assessment from Jamie and Aday. And so the survey is underway, and we'll see what else is percolating. And then Maureen Busby is going to, along with Aday, chair a discussion of this concept of a nicotine-free generation policy, which actually I'm kind of excited about.
Yeah.
I think it makes a lot of sense. And then we'll hear from Carrie on the brand new 24 hours ago performance standards for local public health published by the DPH. And then an update on rodent control, our monthly report. Wrap it up. So without any further ado, in terms of the minutes from September 14th, they looked good to me. Any comments, suggestions, edits?
No, look good.
Thank you.
Cassidy.
Yep.
So I'll make a motion to minutes. Do I have a second?
Second.
Second, Carrie said. Roll call, Paula.
I'm in.
Carrie.
Yes.
Rick, yes. So the minutes are approved. And Cassidy actually worked with the town clerk to get our minutes posted. Actually, there was a little bit of a lag. So hopefully going forward, we'll get them out there as soon as they've been approved going forward.
We are very sympathetic and aware of the challenges of minutes and approvals and posting. We
Yes.
have all experienced that, and
I think
Very
we were behind a year at one point.
we were.
I know.
We were. It was. I mean, it was a COVID year when you guys were meeting like
Yeah.
We were having meetings twice
5 days
a
a
week.
week.
You know.
Yeah, yeah. But still, yes.
Okay, and I don't see any members of the public, so we'll move on to public comment. And I'll turn it over to Aday and Jamie for an update on the health needs assessment.
Hi, Jamie. You can go ahead, please.
Good evening, everyone. My name is Jamie Hobecki. For those of you who might be new faces on the call, I'm a vice president and senior consultant at Pear Associates, which is the consulting firm that's been working with all of you since February to put together a community needs assessment, a community health improvement plan, and then finally finish up with a year one action plan or a work plan. So I'm going to go ahead and show my screen if that's okay. Okay, so hopefully you can see my screen. What I'm going to do tonight is to just provide a high-level update of some of the major activities that have been happening related to mostly the assessment portion of what I just talked about, and then go over next steps so you can see where we're headed in terms of timeline and what some of those key deliverables are. Before I jump in, I do want to mention that it has been a pleasure working with Aday and the community at large. There's been a fabulous planning team that's been established that helps determine and drive some of the pieces. And I know some of you are also members of that planning team. So I just want to say that that part in terms of collaboration and support for this process has been exceptional. So thank you for that. In terms of when we kicked off, as I mentioned, we had a two-part kickoff that occurred in February and then again in March. And that planning team that I mentioned was the primary group with some additional folks added participating in that process, which really went over the scope of services and started to highlight what some of the existing information might be relative to the discovery process and our understanding of Reading in terms of data and needs and what's already happened and what we could learn. In terms of the planning meeting team that I mentioned, or planning team meeting that I mentioned, we've been holding those bi-weekly through April through August. And those have really allowed an opportunity for ongoing input to support the process. And as you can see on the slide in front of you, it's informed the scope along the way. So really identifying what the health framework looks like for Reading and what that means to you in terms of what health is and how it's defined. And then really helping to shape the engagement activities of this scope, which are really the bulk of the work in terms of what we're able to provide you. So these teams work to create an interview guide and scheduling, focus group guide, and help with scheduling locations and recruitment. And then also helped with the design of a survey tool and promotion within the community. In terms of the engagement activities specifically, just to give a high-level overview, we conducted 11 key leader interviews virtually, and those interviews were held between May and early June, and we did have one final interview later in June, but we were able to present a summary back to that planning team that I mentioned in June. We also held focus group sessions, 4 of them, in a hybrid fashion. So some of them were virtual, some of them were in person, and then a couple of them were actually optional, where you could come in person or be online. And we had great turnout for all of those focus groups, and you can see in front of you, they were held in July, and we focused in on trying to think about population groups of interest across the lifespan. So we had youth leaders, residents with a diversity, equity, and inclusion focus, older adults participating, and then I met with your municipal leaders or town leaders to hear from them on service delivery and their insights on the town of Reading. We also conducted a community survey, which is about to close this week. And we've had a great response from the town residents. So we created the survey tool in August, and it's an online survey tool using SurveyMonkey. We also had some paper-based tools available and held them at locations like the Senior Center and the Public Library. The survey, as I mentioned, launched on September 14th and is scheduled to close this week. We had an initial goal of wanting to get at least 100 full surveys, and we were saying 100 to 150 full surveys completed, and I'm happy to report that our actual number as of this morning was 180 surveys fully completed. And fully completed means they went through all 4 sections of the survey tool. And you can see the breakdown in front of you on the slide. So section 1 talked about their own individual health status and their perception of their health. And we had 244 folks complete that section. We had a section 2 that talked about access to services and barriers to services, as well as a little bit about their perception of Reading as a community. And we had 225 folks complete that survey portion. And then we had community health needs, a session, excuse me, where we talked a little bit about what are some of those high level health related needs, and then what are some of the community broader design level needs. And as you all know, and I'm sure from being on the Board of Health, the definition of health for this needs assessment has been very broadly defined. So we're not just talking about the presence or absence of disease or somebody's ability to get to healthcare. We're talking about some of those upstream drivers as well. So some of the economic pieces or social pieces like social isolation or access to affordable housing. So that's really comes out in that section. We had 183 respondents. And then lastly, we had a basic demographic section just to get a sense of the characteristics of the folks who were completing the survey. And we had 180 people successfully complete that section to round out that 180 full surveys completed to date. just to give you a quick sense, I'm not going to go into too much detail here, but just to give you a quick sense of the framework, as I mentioned at the top of the call, we worked with the planning team to really decide what that might look like. And there's this strong pull towards the social determinants of health. So a lot of the engagement activities, or most of what I've talked about, are related to this framework of really thinking about neighborhood and built environment factors. So how inclusive a community might be for folks of all ages and abilities. A social and community structure. So thinking about things like inclusion and culture and language and some of the other barriers that might exist to service delivery. And I already mentioned social isolation and folks not feeling connected to community and not knowing where to go to get services. Education and development. So thinking about the youth in particular and what their health status is, from healthy behaviors to their mental health and ability to gain access to supports and resources that they need so that they can participate in a productive education. Health and health care, which tends to be more of the traditional thing that you see within a community health needs assessment. And really that's about chronic conditions and healthy behaviors. Also thinking about healthy aging more globally, and how do you start to build out systems of support so folks can adequately age in place even, and what that might mean for supports and resources and connections to services to support somebody's ability to do that. And then lastly, someone's economic stability. And we've heard a lot about housing in particular, in terms of affordability of housing, but then also this notion of stigma, which I think is an interesting one. So folks really worried about potentially asking for supports and services when it's economically related, just for fear of what folks might think about them and their situation. So next step, so current status. So where we're at, as I mentioned, we're just closing up the survey tool this week. We will be, as of right now, looking at those survey results and coming up with a snapshot summary specific to the surveys themselves. And then from there, we're going to pull out higher level themes across all of those engagement activities I mentioned. So what did folks say in the interviews? What did we hear in the focus groups? What are the surveys saying? And find those common themes across all of those qualitative areas. And then also try to find the novel pieces as well. You know, we certainly expect that there sometimes won't be alignment across the various mechanisms of gaining information and collecting information, and that's important to note as well. So we'll look for those outliers as important pieces to inform this process as well. We'll take all of that information and draft a findings report, and we'll present that back to the planning team that I mentioned. So we're in the process of scheduling monthly meetings with the planning team to support this process. So in November, we'll start with presenting the findings back to that group. And then at a second meeting, we'll start to talk about what are the priorities based on those findings, where we really want to focus our work. And then in January, we will switch gears and start to talk about the solutions. So once we have those needs identified in December, in January, we'll take them and think about what are the strategies and opportunities locally to move to action. And that might mean that we're looking at existing resources to support some of this work. We'll look at best practices across the country and some of the evidence-based resources that we have. And then also, you all will be the experts on determining funding and resources and other capacity that might be needed in terms of moving on some of these needs items to make sure whatever we're presenting back to you is as realistic and actionable as possible. In terms of setup for that meeting, we have one planning meeting scheduled for that, and then also potentially having an in-person meeting of some sort that could involve more partners to come to the table and think about what that improvement plan might look like. And then lastly, once we have the strategies identified, we'll really get more into the blades of grass and start to talk a little bit about high-level action steps, who might be responsible, what resources exist, and really start to build out that 1-year work plan for supporting action on the items that have been identified. So to summarize, we have the assessment report that will be tied up in November and December, and then we'll have the community health improvement planning process in January, and then we'll finish up with that improvement plan in February. So at this time, I'll stop sharing my screen and I'll open it up for any questions, comments, or concerns.
I did have a question about when this information will come back to the board. Because it looked like there was a lot of planning group meetings for reviewing the data.
Yeah, let me just sort of tag on, because that was one of my questions as well. I think that I think it's good to have the planning group meet to kind of review the assessment findings, but I think we need a meeting, a full board meeting in the with the public that's really dedicated to talking about what the themes and the problems we've decided based on the information is. And then at a subsequent meeting where we've all had time to digest it and so forth, then, you know, start to talk about potential interventions and actions. And so we actually had previously talked about, you know, not having a meeting in December, but we may need to have a meeting limited to this conversation in December based on your timeline, Jamie, to just to talk about the findings and the conclusions of what the issues are. Because otherwise I don't think we should kind of merge the findings with the interventions. It's too much to do in one meeting.
Absolutely. And it's the findings piece is actually separated out into 2 meetings currently. So the first is to hear the results from the engagement process in pieces. And then we would leave and let people digest, really think about it, and then come back to the table again to identify where those areas for action really are and what areas you want to work on. And then the strategy piece is another meeting, a separate meeting from that. What I'm hearing you say, Dr. Lopez, is perhaps that second meeting is the board meeting where we're coming back and talking about what are those priority areas. Is that correct?
No, what I'm saying is that we should have a meeting where there's a presentation of the findings of the assessment and all the data that you've collected from other sources. So there should be one meeting that really presents the information that you've gathered.
Okay.
At least in my mind, we would
for the board.
add one meeting, and then a second meeting subsequently the following month. We would then have a discussion about possible, you know, approaches to addressing those findings. So I'm kind of separating findings from interventions, separate full meetings, because it's very important.
Rick,
Sure.
could I suggest, would it be appropriate to invite the working group to come to one of our meetings then, rather than having Pear present the information to the working group and then come back and present it to the board? So maybe the working group folds in with us for, that's one approach, would fold in with us for the presentation of all the findings, and then the subsequent meeting with the discussion of what are interventions or approaches or the like. Thoughts?
We can certainly do that. do people feel that I'm trying to remember, are the planning group meetings public?
Yes,
They- Okay, so that's,
they're posted because so that members could join. Yeah,
right, because I
Yeah.
think actually the 3 full board members on the planning.
Exactly.
Yeah.
Yep.
So that would be fine, because I think that it would be important for the public to at least have the opportunity to hear that, the data as well.
it's just a thought, and I don't know, I mean, there may be, pluses and minuses to presenting data to just the working group, because I know it's a little bigger. Maybe, maybe you do want to do it twice so that we each get our opportunity to work it through. And I think Jamie, certainly that's your expertise in terms of how big a group do you want to facilitate and walk through this? But just thinking about how to consolidate and make it efficient for folks.
Sure, I think all of that is great feedback, and I'm looking at a day, I'm thinking that perhaps we can connect and talk about what makes the most sense in terms of a modified timeline to make sure everybody's included in that findings piece in particular.
Absolutely.
The other question I had was, you've emphasized the findings of the interviews and focus groups and survey, which I agree are critical and really important and most relevant. But I think we had talked, and I think we had talked about having also data that might come from other sources, from hospitals, from the coalition survey, from the state DPH might have. I know that data isn't always carved into at the town level, but to the degree it is, will that kind of data also be incorporated?
Absolutely, yes, that's a great question. That was a piece of our discovery process as well that I didn't explicitly mention here. So we have looked at existing needs assessment reports from the hospitals, and some of the other sources online, even nationally, that are pulling better data that as available for, like you said, local consumption. So whenever Reading is possible, we've been pulling that into an indicator spreadsheet so that we can pull it down into a needs assessment as well.
Great. Thank you.
Awesome.
Any other questions, comments, suggestions for Jamie? Great. Well, thank you for coming, and we're looking forward to it. It's exciting.
Great. Thank you very much. I appreciate it.
Thanks, Jamie.
You.
Thanks,
Bye.
Jimmy.
Bye.
We'll be in touch.
All right. So next on our agenda is a discussion of the nicotine-free generation policy, and I'd like to welcome Maureen back to the board.
Came back.
I came back.
Hi, Maureen.
Hi, everyone.
Hello.
So,
Do you want me to just jump in?
yeah, why don't you?
Yes, please go ahead.
Okay. So first I'll explain the nicotine-free generation, what that policy is and why we should even think about it or look at it. And then I'll give you an update on what's happening in some other local communities. So first of all, just a reminder, and I know you all know this, tobacco use is still the leading cause of preventable death in the US. Every year, 480,000, almost 500,000 Americans die prematurely of smoking-related diseases. Billions of dollars are spent on smoking-related illnesses, and that's been going on for decades. It's going on now. What have we done about it? First, the feds have done some things. They banned flavored cigarettes in 2009, with the exception of menthol. They left menthol. They exempted menthol. And the US also has significant restrictions on TV and magazine print advertising, not so much on the newer social media kinds of advertising. They probably need to look at that again. The state has done a lot. Massachusetts is a leader in the United States on tobacco control. And the most recent big tobacco control regulation, or law, I should say, law that the state passed was in 2020, and that's the flavor ban. And our flavor ban here in Massachusetts does include menthol. So when that ban went into effect, it actually took Newport menthols, for instance, which was the biggest selling cigarette in Massachusetts, off the shelves. But also local boards have made a huge difference. Local boards led the campaign 22 years ago for smoke-free workplace law, for instance, against extreme pushback, especially from restaurants and bars. They had the conviction and the courage to adopt this progressive policy. And now we can't imagine going into a theater or a restaurant or a bar, or riding on the subway or a train or an airplane where somebody is smoking. Local boards also adopted many tobacco control regulations designed mainly to reduce youth access to tobacco. Our local boards, including Reading, were early adopters of T21, raising the legal age to buy tobacco products from 18 to 21, a pharmacy ban, flavor restrictions, cigar minimum price, permit cap, proximity ban, and other policies. Some of these policies, as I said, have since made their way into state law. So what has all this legislation, regulation, and policy accomplished? It has moved the needle a bit. However, people still smoke, millions are still affected by smoking, and vaping is a serious issue in our schools. We can be proud of what we've done, but the question is, at what age do we want our youth to be given nicotine? Once young people start using tobacco and nicotine products, it may be too late. Once they're addicted, they really have no choice. That's how strong the addiction is. I've mentioned in past meetings that medical professionals tell us that a nicotine addiction is harder to break than a heroin addiction. So one of the communities in Massachusetts, some of you may be aware of this, the town of Brookline, in 2020 passed a bylaw. For them, it was a bylaw, not a Board of Health regulation, because they don't actually have a Board of Health. They have a health commissioner, and then regulations go to the town for a vote. And so in 2020, the town of Brookline passed a bylaw that made it illegal for Brookline retailers to sell tobacco to anyone born after 1/1/2000. So the age restriction that we have now, that was a regulation in Reading before the state law, but then also became state law at the end of, I think it was 2019, that stays in place. That state law, that minimum legal sales age stays in place. But in addition, under this policy, we would adopt a birth date restriction. So you'd have to be 21 to buy, but you will have to have been born by a certain day or have turned 21 by a certain day, whichever way you want to look at it. How Brookline stated it was, you had to have been born by 1/1/2000 in order to be able to buy tobacco products in Brookline. No one who was already 21 would have that privilege, if you want to call it a privilege, to purchase tobacco products. They wouldn't have that taken away. In this policy, unlike the other policies that we've done, which I've worked very hard on for the last 12 years, and I'm proud of what we've done, but they're really Band-Aids. And as the tobacco industry gets, more and more clever and introduces more and more products that are cheap, discreet. I think I might have mentioned in the past nicotine pouches, which are extremely cheap, high nicotine. They're made with nicotine salts, which means a quick hit to the brain. We hear that a lot of people are using them when they go to the gym because it actually makes you feel like you are stronger, so you can lift more. And these are so new that they're not even covered by the state excise tax. That's one of the things that makes them very, very cheap. There's no excise tax like there is on our cigarette products and cigar products, and as of 2020, our vape products as well. So this policy, unlike those others, which now I'm looking at as Band-Aids, actually starts moving us towards the end of nicotine addiction, which again has harmed millions and cost billions for decades. There's no reason to allow this public health crisis to continue just so the tobacco industry can continue to grow their profits. We know nicotine is a poison. One of my tobacco program colleagues often says, nicotine is the only legally sold product in the US that when used as directed kills. So in summary, retailers would have a long time to get used to lower tobacco sales. Each year they would lose just 1 year's worth of people who would have turned 21, those potential sales. And Aday is showing right now, thank you for throwing that up on the screen, Aday. Here's a photo I took from a local store for Zyn pouches. The bottom row there are those Zyn pouches. And then you see that sign that tells you it's $3.49 per 10. And there are 15 pouches in these tins, $3.49 per 10 if you buy 2 tins. So that it's a great promotion. Generally, I see it for $4.49, $4.69 per 10. But this is an excellent price for anybody who wants to have high nicotine content that's very discreet because it's a little tiny pouch you put in your mouth. Your saliva melts, dissolves the powder. And again, it's made with salt, so it goes directly to your brain. I'm hearing from health teachers, or no, I'm sorry, not health teachers, ADs and school wellness directors that they're seeing more use of that among their student athletes and in their gyms. There's another photo that I sent to you earlier today, a day that you might throw up there, and that's the Newport non-menthol, that one. So here's so remember, Massachusetts banned the sale of all flavored tobacco nicotine products, including menthol. And California did the same after us. So what the tobacco industry introduced or came up with and introduced earlier this year is non-menthol Newport cigarettes. And if we can, I don't know if we can zoom in on the words that are right below the flyer, the ad right there. There you go. The ad that's above the display of Newport cigarettes says non-menthol for menthol smokers. They're not even subtle about it. And we've heard from some menthol smokers who quit smoking that the packaging, because they went back to their old traditional green menthol packaging, is a trigger. And what we found was, we were concerned, and what we found was the tobacco industry did not add the regular menthol flavor to these cigarettes. That's why they feel they can sell them in Massachusetts. What they did was they added a chemical, and that chemical mimics menthol. And when you smoke it and you inhale that, that combustible cigarette tobacco, it sends a message to your brain, tricking your brain into thinking you've had that it has menthol. So just another example of how clever the industry is. And then I think I have one more photo that I sent to a day earlier, the pink highlighter. Oh, there we go. This is the newest version of a vape pen. So remember, a few years back, Juul introduced the vape device that looked like a flash drive. Now we have a device that looks just like a highlighter. I can't tell the difference. And actually, when you take the top off and you look inside, it's actually a vape device. So the tobacco industry will keep doing this, They've used the same playbook for years. And as I said, once our youth get addicted to these substances, they often don't have a choice. They have to have their nicotine hit multiple times through the day. And vaping cessation smoking cessation is very hard. Vaping cessation is even worse. So thank you for those photos, Aday. In summary, the retailers have a long time to get used to this policy and slightly lower tobacco sales each year. And admittedly, it will take a long time, but it will be a step towards a nicotine-free generation. Lots of lead time, no one loses a privilege, and it's actually easier for the sales clerks to check IDs because they only need to remember one date. In Brookline, it's 1/1/20. If that ID shows anyone born after 1/1/20, they can't buy tobacco products. And right now, they have to change that date every year. This last picture that Aday showed is actually, I think it's Wakefield. Oh, no, it's Melrose, it's Melrose. So,
Melrose.
yep, Melrose, sorry about that. Our state legislators, so for Melrose, it's Jason Lewis, whom you all know, I think, and Rep. Kate Librigera-Bedian. In Wakefield, it's Jason again and Kate again, and also State Rep. Donald Wong. And in each of those communities, they signed a letter of support for this policy. And also, Jason Lewis has indicated his interest in filing a state bill. But we know how long, generally these kinds of policies start at a local level, local boards adopt them, and then it moves throughout, throughout the state, and then we reach a critical mass, and then the state legislature has more willingness to take it on at that point. So that kind of wraps up my prepared remarks for you. And now I'd love to hear any questions you have about the policy. And about what's happening in other communities. Actually, next week, Tuesday night, Stoneham Board of Health is holding a public hearing on this policy. Wednesday night, Wakefield has a public hearing, and Thursday night, Melrose has a public hearing. So it's a lot of activity next week, so stay tuned. But also, I'd love to hear questions from you.
Can I just ask one quick, thanks, Maureen. So when you say that those communities are having a public hearing, they've moved on and now they're having a hearing to consider adoption of a regulation, yes?
Exactly. I made presentations to the board similar to this tonight, a couple of months ago. I think it was August, yeah, in August, mid-August. And then they voted to hold a public hearing and get input, and I'm sure we'll get a lot of input. And then they'll consider that input and then make a decision on the policy.
Thank
Quick
you for this. I
question.
know it's helpful to know, I actually started in public health when the Smoke-Free Communities project was still a baby. They talked about the coalitions, having coalitions, but I know it's helpful to know what your surrounding the status on on surrounding communities, and I know the distinction between discussion versus hearing and the like. So thank you for explaining that.
So, what would you say to people that believe smoking is a constitutional right?
Oh, I know. We get that question or that pushback, and I believe probably in Reading back when we did T21, there was changed the legal age from 18 to 21. There was quite a turnout, and I'm sure that was one of the objections that came up. There is no constitutional right, constitutional right to smoke. In fact, if we had a constitutional right, what I would like to see is one that protects clean air for everybody. But people will raise that and say you're stepping on our rights and our privileges. But when we put these kinds of products in front of underage kids whose brains aren't fully developed, and we entice them into using these products, like for instance, Juul did, and our state attorney general, along with other state attorneys general, sued Juul, and Massachusetts got a $41 million settlement from Juul for using practices that would entice kids to smoke, because we know if you can hold off smoking, vaping, using any of these nicotine products until after the age of 23, 24, 25, you probably will not become a lifetime smoker or user of nicotine products. But if you start before then, you have a much greater chance of becoming becoming addicted. I can't remember the exact number. I think it's 90% of adult smokers started before the age of 21. So if we could keep these products out of kids' hands, and we just can't, because the industry comes up with new products all the time. They've got billions of dollars to do research and billions more to do advertising, and so we're constantly finding and fighting new products and trying to figure out how to increase or decrease youth access to these products.
Can I ask a follow-up?
Mm-hmm.
The harm that we would be preventing, what information do we have in terms of, what is that public harm? I mean, we know we're talking about youth and being exposed to addictive substances. early before they can make effective decisions. But there's larger harm, I think, that's done to the community, done to, that costs the community. Is there any information on that?
Yeah, so boy, that's a huge topic. So
I know.
first of all, we know since, I forget, 1956 or whenever it was, when the Surgeon General's report came out about how bad smoking was for us, and secondhand smoke. People, as they realized smoking was bad, they didn't realize secondhand smoke was so bad. So we have a lot of data. We have decades of data. We know that, and we found out through all that research that it wasn't just lung cancer, but it was stomach cancer and bladder cancer and other health issues, affects heart, affects people with diabetes and so on. And then the industry came up with these newer products, which we know so much less about because they just haven't been around long enough. We don't have people who have vaped for 10 years. We do have data on, and I don't have it in front of me, but there is data on youth use of vaping and some of these newer products. None that I'm aware of on Zyn or these nicotine pouches because they're just too new. But we know that medical professionals have reported lung issues, respiratory issues among teenage users of vape products. We know that a vape is made of an oil. You heat that oil becomes an aerosolized mist. You breathe that into your lungs. So that alone is damaging to lungs because you're coating those small airway passages with oil, essentially. We know that the oil contains nicotine, which is a poison. We know that, we know a little bit about nicotine salts, not as much as we know about regular conventional nicotine that's in tobacco products and added to tobacco products to make them even more, have a higher nicotine content. We do know that the coils that are in the vape devices, which heat the oil, small fragments of the metal that those coils are made of break off and they end up in the oil that then you heat up and becomes aerosolized and you breathe into your lungs. There's cadmium, there's nickel. We know those are cancer-causing toxins. But again, we don't have the years of data to say, well, somebody who smoked this much over 10 years has this great a chance of getting whatever the disease or ailment might be. But we've seen enough, the medical folks have seen enough to be very nervous about it and cautioning us about it. And we certainly know enough about addiction generally. And now what we know is we have a whole generation of kids who have much higher rates of mental health issues. And some of those are, it's hard to know, the chicken or the egg, which came first. So it's hard to know, did you have a mental health issue and self-medicate to, try to soothe your anxiety or whatever with a nicotine product, which we have heard of in anecdotal reports, or did you start vaping using these products and that brought on some other, mental health issues? Because we know that withdrawal from these products is really difficult. And we know that especially, kids in school who have a 50-minute class, by the end of that class, teachers tell, kids are jittery and they can't wait to get to the bathroom to take a hit of their vape. Well, now we have these little, this is a tin of Zyn pouches, and I'm not sure you can see this. I wish I'd sent the inside to a day, but this is a little pouch of nicotine salts. That's what's in that tin. And you put that between your cheek and gum. And as I said, you secrete those dissolved powders, and it's a quick shot to your brain. It's a real buzz, I hear. So that's kind of just a generalization of the harms that we know that these products cause. In addition to that, the debris that is being thrown out that I see all the time, used vape devices, those are actually hazardous waste. And we haven't even begun to address how to remove those from, gutters and store parking lots and that kind of thing. But that is accumulated hazardous waste.
Thanks, Maureen. And then, so I think, if we think just thinking, so I mean, I know there's probably American Dental Association info about, you know, impact in mouth cancers or teeth, since we're talking about those products. And then, you know, there's the costs of providing the services to support the cessation or the cleanup and the like. So, interesting. mean, this is
Absolutely. You know,
always the tricky-
you brought
Go
up a
ahead.
really good point that I have to jump on, and I haven't even addressed that. The lost school time, the lost education time when kids have to be treated for cessation for these products. I did a presentation to the school nurses at the Northeast Regional Vocational School in Wakefield the other day, and what they were asking me for was two things. What can they do to educate the parents, and what can they do to help the kids that are already, you know, addicted to these products? Because they know that you can't just take these products away. The kids are addicted and they cannot concentrate and they have to leave the classroom. Most of our schools have moved towards or are moving towards not disciplining kids for a chemical violation, but using more restorative practices, using a diversion program for kids who have a addiction problem. But I haven't really even built that into any, you know, presentation I make. And I think it's a really important one. It costs us money to help these kids with these addiction issues, and it costs them time in the classroom.
So I'd like to make a few comments. You know, since the day and I talked about this a couple days ago, you know, done some research, and you know, I remember reading 6 to 12 months ago about New Zealand passing this across their entire country. This, you know, setting a date after which you can't purchase tobacco. And at the time, I remember thinking, what a great idea. Never thinking, gee, maybe we could do it here. And then as I've been looking at this in the last day or two, apparently it's really an international public health movement. There are countries in Europe and you know, Eastern Asia that are talking about implementing this kind of policy as well, as a way to address, you know, tobacco addiction. And so I guess maybe we're a little bit late to the table, even for our fellow towns right across the border here. But you know, I think personally, from my perspective, I think it makes a lot of sense. You know, as I kind of looked at things, kind of did some Googling and so forth, what's interesting was that I came across this statistic that 70 to 80% of smokers would like to quit. And 50% of smokers try in any given year to quit, and only 1 of 3 are successful. And so, you know, the smokers know what the problem is. Young people who are subject to peer pressure, wanting to look cool and so forth, don't realize necessarily, obviously, what they're getting into. I also read that the town of Brookline, which I think is the first town to have passed this kind of regulation, had a lawsuit sort of presented to it about it on a couple bases of constitutional rights and so forth. And the lawsuit was dismissed a year ago, last July, by the Superior Court, finding no basis for this kind of policy being not constitutional or somehow not legal. So that's nice to know that there's actually already been a court case and it's been addressed and resolved. I don't know if that's being appealed. I didn't see anything.
Yeah, there is an appeal.
There is an appeal.
And so it went to the appellate court. The industry appealed, went to the appellate court, and I didn't realize that this happened, but the SJC will look down at the cases that are in the appellate court and sometimes pick out cases and pull them up directly to their level which is the top level in court in the state. And if it's broad reaching, or they think it's going to come to them anyway, or whatever their reasoning is, and they took this case from the appellate court and brought it right up to the SJC. So oral arguments are next month, and then within a month or two, we expect a decision from them. We're glad that they skipped the appellate court, because it'll be nice when this is all, all decided.
Sure.
But when I've talked to other boards, what I've suggested is that I think if they're interested and they want to move forward, hold public hearings that'll help us educate a lot of people, get the interest, do the dialogue, but don't vote on the policy until after the Brookline decision is made.
Okay.
And then we can do all this work. Just today, I was delivering letters to all the stores in Stoneham to let them, we've reached out in other ways, posted the meeting and sent electronic versions and so on. But I hand-delivered letters to Stoneham retailers to let them know that there is a hearing on Tuesday night, and everybody can come and speak to it, and we can do all this research and educating, and then be ready for when the SJC decides on the Brookline lawsuit appeal to move forward, if that's what the board wants to do.
Do you have a date for that, Maureen?
For the
SJC?
SJC, it's hard to know. Some cases actually take months to get through the. I'm not an attorney, but the attorneys working on this. There are a couple of attorneys at the Northeastern University Public Health Advocacy Institute, and they're the ones who are supporting Brookline in this lawsuit. And so what they tell me is, simpler cases might be decided in a month or two, and more complex cases take longer to make their way through that decision process once the oral arguments have been heard. So I hope it's, like if they hear on January 11th, I hope it would be January. I mean, November 9th is what I meant. I hope it would be January, but yeah.
So our next step is to hold, you think, is to do a public hearing.
Right, if you're interested. And by the way, a public hearing is not required for the Board of Health to pass a regulation, but it's been the protocol that you've used and most of the towns around here have used.
Yeah.
Whenever you've adopted a new policy, not an updated policy like you did last year with the state law, just updating your regs, but a new policy, to hold a public hearing. So, I think that's a good idea. It's full transparency, gives everybody a chance to speak to the issue.
Yep.
Just from a technical point of view, when you look at the tobacco regulations that we passed painfully, finally in May, in the spring.
Deliberately,
yes, after much deliberation. We really, I think, and I could be wrong, and this would be a good question for town council, it looks to me that there's only one sentence in that regulation that would need to be changed. There's one sentence that says, you can't sell tobacco products, and tobacco products meaning anything containing nicotine and all that, for anyone under the age of 21. And it would seem like you could simply change that one sentence to, anybody born, after such and such a date. It doesn't have to be a lengthy draft regulation. It would be an amendment to our current tobacco regulations.
You're exactly right. It's actually like 2 lines to add to the legal age part, and then maybe a paragraph that just adds, and anybody who violates that, similar to everything else. In fact, I'll send it to a day right afterwards. I don't have it in front of me, but the letter that I delivered to all the Stoneham retailers today had the policy statement in it.
So
You're right. It's very short. It's very simple.
if we were to go with this, what date would you recommend? Because I don't think January 1st, 2000 is realistic. People after that are already.
Thank you. Yeah.
Old. And also, I'm a firm believer in standardizing things. And I don't know what date Stoneham, Melrose, and Wakefield are putting on their regulation or what they're proposing, but whatever they're proposing, I think we need to be in line with what they're proposing.
An excellent point.
2000 makes any sense. I don't
Yeah.
think.
Yep. No, so that's what Brookline did in 2020, when they passed their regulation, they made the floor 1/1/2000. If we were to do it now, I would recommend that you put it a year, the effective date a year out. So your effective date wouldn't be like 1/1/24, it might be 1/1/25. So we have long lead time to educate the store owners, educate everybody, put up signs, get the customers used to it. It doesn't change anything for current customers who are actually legal, but it will for young people who will be turning 21. So yeah, I recommend a long lead time, lots of education, and then the floor would probably be 1/1/2004, I think.
So,
So that would be no one born after 1/1/2004 would be able to legally buy tobacco products in Reading.
So I've been doing some thinking about this, and I mean, you guys feel free to jump in if you want, but I would think that we would leave a buffer in between. So, I mean, if you're turning 21 next year, we shouldn't pass a law today that'll stop you from being able to buy it next year. So I'm thinking we should put some kind of age buffer in between and actually pick the age we would like to target. So if you want to target the 15-year-olds or the 13-year-olds, then it should be, January 1st, 2010. Instead of, I mean, if we do 2004, I'm 20. 3 months down the line, I should be able to buy, nicotine products. I've been dreaming about that all year long. And then somebody passes a regulation that stops me from doing it. So where I'm getting at is, I think we just need some kind of age buffer in between. That's just what I'm thinking.
Well, I
I'm
think we would-
remembering the change in the drinking age and the same kinds of conversations. Because I'm old.
Kevin,
That's a great point, Naday, because all I was thinking, and by the way, nice to see you, Maureen, always.
Thank you.
All I
too.
ever think with these things is implementation. That's kind of, the forefront of it seems like a great idea on the forefront, but I always like to think, okay, what does this look like tomorrow? Here it goes into effect, and what happens next? So I had a couple questions. One, I think Aday makes a spot on point, because Aday, you're 20, you're not waiting. You've been smoking since you were 17. Now you're cut off. So that's the reality of it. So I think what you're proposing makes a whole heck of a lot of sense in that regard, because I think people, the one thing I've learned about being on this earth is you cannot try to move the human condition in a direction. No matter how hard you try, they will move right around you. So unless it's all in, that's just how it's always going to be. So I'd agree with that, certainly. But I'd be curious, Maureen, now that Brookline's had it, what have they seen on that side of it? Not the implementation. That sounds like that goes pretty smooth. They look at the date. Sorry, can't sell to you. And that sounds pretty smooth. But have they looked back to try to look into, are we making the change we want effective, or is it just people because we'll just go to the next town over, circumventing it? And I get it. It's kind of the long draw, and the state probably needs a bunch of communities to do this to really be able to drive it at the state level. So I kind of get the long play of the whole thing, but I'd just be curious to see if they're doing any kind of follow-up data on the other side of it.
So, and I've heard discussions about that. I actually did some store inspections in Brookline for a colleague of mine, and when I went into the store and I do my little speech about the state law and this, and which I do with every store that I go into, a re-education every single year, they'd say every single retailer knew, yeah, if you're not born before 1/1/2000. So the retailers got very easy training for the retailers. The problem is Brookline is a college town. And Brookline is actually fairly small and bordered by communities. That's why we're trying to do this as a region and do all the communities in my region. And then I know Beverly is interested. I know North Reading might be interested. I know Somerville is interested. So we want to spread it out so that we get some kind of cushion around us and then keep growing that much in the way that smoke-free workplace law happened. And then have the state, be ready to pass a law. And this will take, a generation. That's why we call it smoke-free generation, or tobacco-free generation is what Brookline called it. We'd like to change it to nicotine-free generation because we want to focus on the nicotine and the addictive properties of nicotine. And it's all nicotine products, not just tobacco, not just smoking. So I think it's important to have a fine line, like a drop dead date. This is the date that it's going to be effective. And then it has to be this birth date, period.
Sure.
I'd be cautious about any kind of like grace period. But in terms of effective date, you can pick any effective date you want. I think New Zealand, I think they picked 5 years out. I haven't read that article for a long time, Dr. Lopez, but I think it was like 5 years out. And then I think last week, the UK Prime Minister said he wants to see a tobacco-free generation policy for all of Great Britain. So it's moving, it's happening, but I think it's way early for anybody to have data, and Brookline especially is just not an island. And I think it'll be very hard for them to track health of their residents. But I'm glad they did it. I'm glad they were willing to go out on a limb and be the point of the tip of the spear.
I think, like I said, I think it's a worthwhile idea. So the couple of things that I would be curious to find out, have you heard of anything at the state level for helping those with the addiction, right? So if you're going to take something away, you can't just leave them, kind of out in the cold. Is there any kind of money funding that we can tap into?
So the $41 million settlement from Juul, when Andrea Campbell announced that, she said that the money would go to education, prevention, and cessation treatment. So there's 41 million coming to the state. And I know our roads are in bad shape and bridges are in bad shape, but I hope that money does stay in a pot that we can use for prevention, education, prevention, enforcement, and cessation. Because as I said, it's very tough to quit smoking for adults who try and try and try. With kids, vaping cessation is really hard. The only treatment center that I know of is Children's Hospital, has a fairly new vaping cessation clinic.
Okay.
But for the rest of us, it's, yeah.
To me, I see those things going hand in hand, or should go hand in hand anyway. But
Yeah, I
Hasn't
agree.
the state had a to sort of quit smoking helpline for years?
Yep, we still have it.
Counseling?
Yeah, we used to have programs even in the town of Reading, because I used to teach it. But that money was all from the tobacco tax, if I recall correctly. Is that right, Maureen?
You're correct. And some of the money came from the 1998 tobacco settlement. And we still have the quit line. In fact, one of the signs that stores have to post, and I checked to make sure that they've posted it, is the quit line toll-free number. The problem is kids don't make phone calls, and kids are not going to call a toll-free line. The Truth Initiative does have a text tip line for kids, and one other organization, it might be the American Lung Association, I forget right now, but and when we hand out resource material to school nurses, school guidance counselors, those kinds of folks, there is a list of resources, and some of it is text-based for kids whom we know will not make a phone call to an 800 line. But the 800 line still exists. People can call, adults they can get patches, they can get so many calls worth of counseling. I forget the exact data on that.
this would certainly be something that the coalition would have a lot of interest in as well.
Absolutely.
It could be really a tip of the sword type of organization as far as helping the kids.
And I did reach out to Erica last week, I think. Once a day, and I set this, on the agenda. I reached out to Erica, and I do want to get together with her and give her the same. But I just haven't had a return call or email yet, but I'll keep following up with her and get on her calendar and share this with her.
So, just to kind of wrap this up, one way to approach this in terms of logistics could be that, that Maureen and Aday, work to, maybe put something together in terms of how, an amendment to the current tobacco regulations would look. Maybe, and even if there's, for the purposes of informing the board members, maybe even if some of these other towns, we can see copies of, their amendments so that we can kind of get a flavor of it. And then at our next meeting in November, we can have a discussion about what the amendment might look like for tobacco regulation like this. And, we could, if we could agree at that point, we could then decide to have a hearing. It could be in January. It sounds like we're probably not going to do anything anyways until January, but we could have a hearing in January, either part of a board meeting or separate, and then be prepared to vote on what we agree subsequently, and that might sync up with what the SGC is timeframe is. Does that sound like a plan for this?
Yeah.
Does. The only recommendation I would make, if we're going to hold a public hearing of this kind, or a public meeting, I don't know if we're meant the same thing, Rick, or you're going to do two different ones, but I would have it at a public venue. I think, a lot of people would probably not want to have their face plastered on here as they're making comments on something like this. So I think
You'd have it in person.
like an auditorium, you could use the PAC down at the high school or something like that. You put the mics in the center, in the alleyways like they do for town meeting. Same type of thing. Just a
That's a
suggestion.
good idea.
I think you get a broader attendance and get more thought. Even negative thought to me is always useful information.
Sure.
And just one more thing, how do we address people that purchase tobacco products for minors? What are we going to do about that?
Mm-hmm.
Well, isn't that already illegal?
It's catching them.
You
It
mean
is illegal,
it's
but
illegal, but we don't catch them, is what you're saying. Yeah,
correct.
right. Well, the thing about this law is I kind of feel like I'll be long gone, but if it ever happens at the statewide level, I'm not expecting it, a Reading passes this or even a region passes this. It's not going, people are going to go and purchase tobacco products outside. And if they're going to give them to minors, they're going to give them to minors. But at some point, 20, 30 years down the line, it's particularly if the state adopts it, and who knows, by then it may be a national effort. I think we may not see it in this room, but at some point we could have a tobacco-free society.
Be great.
With an investment in the future.
Yes.
future
Yeah.
generation.
For sure.
Sounds
It's
good.
just so insidious. It makes me sick.
Yeah.
Yeah.
So addictive.
One of the products that I've heard about that I haven't seen in this area, but I know is a problem in New York State, is the nicotine gummy.
Oh,
So it looks just like gummies. So imagine having nicotine gummies around that, some adult uses them, buys them legally, uses them or whatever, and then a child gets a hold of nicotine gummies. So yeah, it's like somebody said, it's insidious. It's
it's lethal to little ones.
and lethal to little ones. Absolutely.
Yeah.
Yep.
Okay, so thank you, Maureen. And
Thank
and we have a next step of you and Aday working on some way of amending the tobacco regulations that takes into account the concerns around a day raised and in terms of dates and potential effective dates, something that we could then address at our next meeting. And then also if we could kind of see what other towns, what their laws are in terms of what they're passing, and have that, we'll have a discussion at, our next meeting.
Sounds great, and I'll follow up on these things. I'll give a day an update on the meetings next week, and I can share, I think the Stoneham one might already have been posted there. Their amended, the regulation that's going to be discussed, which is the amended regulation, but I'd have to check, but I'll get that to a day so he can share it with you.
Terrific.
That's good.
Thank you.
Thank you very much.
Great.
Thank you.
Thank you so much, everyone. Have a good rest of your meeting and a good night.
Thank you.
Bye.
Very
Bye.
nice to see you.
Okay. That was interesting. Carrie, do you want to update us on what's going on?
Thank you, Rick, and thank you, Ade, for giving me a little time to talk about this. I'm very excited. So yesterday, the director of the Office of Local and Regional Health for the Department of Public Health presented to the Public Health Council, announcing the release of public health standards for the first time in Massachusetts. And they're basic, but what it does is this goes hand in hand with the shared services work that Reading is part of with that Town of Andover collaborative arrangement, and the training hubs. And what this does is it provides kind of a baseline for boards of health and health departments across the Commonwealth to know what it is that you need to do in your community and what are the basic training requirements for the staff that you would need to do that. It is only in what are the statutorily required public health responsibilities right now. It's just the first phase. We know that public health has a very broad remit, and this work focuses on these 5 areas. It's administration, it's community sanitation, it's environmental protection, it is disease control and prevention, it's food safety, and housing. So those are the areas that are statutorily required. And for longer than I've been doing public health, everyone knew that there were laws and requirements, but there was no standard of performance, and there was no standard expectation, and it was very difficult to get a handle on what it was you were supposed to do. There's no dedicated funding in the state, and you ended up with communities all over the state, everybody doing it differently. I remember when I had my interview to join the board back in June of 2020, and I made reference to this work, and I remember saying that way the kind of inspection protocols and standards will be the same from one town to the next. And it stuck out because Carlo Bacci was one of the interviewers, and he has experience as a business person working in different communities. It's like, gosh, that would really be nice if it was the same, if you didn't have to operate in different communities and have different interpretations and expectations. And we're finally getting there. I think that the standards will make it possible. We're a little ahead in Reading because we're doing our community health assessment now, so we're a little ahead. Yay! And we have we'll have some information for our community health assessment, and we will be well poised to be looking at what are the things that Reading needs to be able to provide high quality public health services to the community, and how do you do it you have to handle the how do you do it well, but then also how do you do it with limited budgets? We hope that, you know, part of this is that there are state funding available that's funding these shared services pieces. Right now, the average municipal funding in the state for a health department is about $16 per capita. And with grant funding, that's going up to, I think 42 was the high that I saw there. You know, we're trying to establish a benchmark for now. I think the New Jersey benchmark is $35, and that's the one that's being used as sort of a, we think that'll work. They're the most similar to us in structure and service needs. But it's a question of, all right, well, how do we do that? There's never been dedicated funding. We've always, it's been kind of, do you have access to a public health expert? What are the people on the board know? Did you hire somebody? Can you afford to hire somebody who really knows about this stuff? And how do you afford to hire somebody who knows about septic if you only have a little bit of septic? So these standards go a long way towards helping us solve some of these things. And I know shared services will talk about this a little bit more, but this is really a big deal. And if I can I share my screen for a minute? I just want to show the website, the state website is set up now. Oops. Nope, not that one. Which browser? You can go and see. Yes, here we go. All right. Now, where's my, sorry, gotta go back to, you know, I still say, we've been sharing screens for 3 years and.
You can send it to me and send it to me at Cassidy and
Oh, okay. I'll send you the link. Yeah, because it just because it's fascinating and you can see data about sorry, there we go. I'm gonna drop the link in the chat. I'm gonna stop talking because I promise it'll be worth it. Just bear with me a second while I roll around here. Trying to get to the chat. Here it is. No.
yeah, just send it to my email
Okay.
and we'll put it up.
Okay.
Carrie, are you looking for the grid that shows the performance? No.
No, it's a fabulous, here it comes a day. It is a fabulous link and it's in the performance standards press announcement. If you go down to, there's a map is what I'm trying to get us to. There is a map that you can hover over and you can see where where the communities stand in terms of their meeting of the existing standards. You can see what the barriers to meeting those standards are. And then you can, sorry, a day. It's not working. Here it is. And data. And you can hover over each community. You get the population, you get where they are in terms of standards, you get what are the barriers for standards. You've got these benchmarks now for, oh, okay, how do we address these? So you have a little bit of a path forward that will inform shared services arrangements as well as individual communities on how they make decisions of what do we need to prioritize. And I will say, not that I'm competitive, but I am. And I'm losing right now. So the shared services arrangement that Reading participates in is, well, I don't know if I'm losing or winning. Shared services that Reading participates in, they have 85%. They're at a good place. They at 85% of meeting the standards. Whereas the one that I am managing is only at 83%. But the beauty is that we know what it is that we need to, how, where do we need to tackle it? In our case, it's a need for training.
Can I just share the actual, not to go into any detail, but just to give people a sort of idea of this is if you go on the website that Carrie's referring to, and you actually want to see the standards, they're listed here, and you could see down here, they're broken out: environmental health, tobacco, disease control, workforce standards, and so forth. And it will take me some time to wrap my head around some of this, because it's pretty, well, actually, can I do this? Oh, there it goes. So under environmental health, it lists topic areas, directs you to, the general laws pertinent, the summary, and what a sort of contact in the state government would be. And you could see it for tobacco use, disease control, and so forth. Interesting, under environmental health, what I didn't realize is that there was something here about funeral homes. Do we license funeral homes? I didn't realize that.
Unless we delegate it.
We used to, but now it's done by the town clerk.
Oh, okay.
We have the authority to delegate it and rearrange, but yes, it's our primary responsibility.
So
So,
anyway, if you have a chance to look at it, it's pretty extensive.
wait, I really want, it's the capacity assessment database, a day. I don't know if you've had a chance to look at it yet. You're probably too busy.
Actually, I did.
There we go.
Let's just Google it. Cassidy, can you just Google it?
Yeah, so I'm sending you the beginning, it just sent you. So it's data visualization.dph.mass.gov. I don't know why I can't copy and paste the URL effectively. But it's so good that you have to write a day. It's really good.
Yeah, yeah.
What's the state average?
The state average is 79%. And then, yeah, I mean, you end up with a variety of, there are different groups, and what you can see is some of this is, the distribution. There's a lot of communities in the western part of the state, and then in the, like above Worcester, north of Worcester, that are, they're more rural. They're about 75 to 80%. And then there are big swaths in, the state outside of the metro, the metro Boston area, outside of 495-ish, where they're below 75%. And and what's been complicated about this has been that the barriers are multiple. Sometimes it's the training, sometimes it's the staffing, sometimes it's the funding, sometimes it's all of those things. And then it's also just the lack of awareness. So kind of like you were saying, Rick, I didn't know we had funeral homes as a thing. There are some things that on that basic list, those 5 pieces, that there just wasn't the awareness of what the environmental health responsibilities were and what the food service requirements are and the like. So so what this assessment did and what the standards do is kind of make clear where the gaps are, and then also what the needed solution is. What's the do we need to do training? So the state's investing in training hubs. They're creating 10 training hubs around DPH is investing in training hubs, 10 around the state that will be focused on figuring out what are the training needs for the groups of communities that they serve, and then working to obtain and deliver that training and make sure that it's available frequently. So for example, housing's always been a challenge because it's hard to get folks standardized. You need to do some field training for housing, and the options to do that are somewhat limited. So now there will be, once these training things are in place, there will be multiple people across the state that are properly trained, standardized in what a housing inspection is, and be able to have consistency across the Commonwealth. So when you look at the map, you can really see their distinct areas. And as I said, Reading and our communities, we're in a good spot. But it's actually right on the DPH website. I don't know why I can't.
We're pulling it up right now.
Oh, okay.
We're gonna pull it up.
Okay.
Are you guys
Yeah.
able to see this? The dashboard?
Yeah.
Okay, I just want to make sure.
Is that it?
Yes. So if you hover over, yeah. See any community, you hover over, you can see where they are. It's all that data, the population, where are they in meeting the standards, what are the barriers, and those on the bottom there, it says SSA reasons for not meeting performance standards. That's self-report at this point. And it may be that as we get into it, there will be some learning, and the self-report might need some modification, but it gives you a target, right? So where we're looking at us, and the findings were that some of the reasons for not meeting standards was a need for staffing, a little bit of a need for training, lack of awareness of responsibility for it. So it's you can see that we're good, right? We're good on community sanitation. We're good on food protection. And you can see where we could improve a little bit, but we are above the state. We are above in general, and yeah, and administration, I think that that's a very common thing across the Commonwealth. There's a lot of work, a lot of documentation, a lot of information that you need to have. And that has not always been prioritized when we have small budgets, and when public health is not well understood by individual municipalities. It's hard to get funding. And the pandemic, laid bare some of the needs for public health and the lack that there was. And we are fortunate that there has been funding. The state legislature has acted to make funding available to support the creation of these standards, the development of these training opportunities, and giving boards like us information so that we can make good priority decisions. So it's a super exciting time. As someone who got to sit in on meetings talking about shared services arrangements and regionalization and how the heck do we do this in Shrewsbury in 2003, it's 20 years now, 20 years gone, and we have some solutions in hand. So I know shared services, we'll talk more. I know Ade, you guys were talking about having the shared services coordinator come in and speak, and I know that they could get into more of the details on this, but I think looking at this is perhaps even more exciting than looking at what all the standards, what the standards are. Then you back into the standards, or back into what are the hiring requirements for each of the positions. That's the other thing. There's consistency now on what does it mean to be a health director? What does it mean to be an inspector? So really exciting times.
Great, thank
As long
you.
as you're geeky like me.
Thank you.
Thank you, Carrie, for bringing this to light. Boy. It's always
That's
good.
great.
Good news.
It is, it's really good news. So, and I mean, yeah, so hopefully the funds keep coming because, we need them. You know, $16 is not sufficient per capita, is not sufficient to do everything that needs to get done. So,
I'm a
Right.
fan of standardization anyways.
yes,
And,
there's,
you know, like when McDonald's first started, the fries in California tasted differently from the fries in Massachusetts. And then somebody came up with a bright idea of standardizing it.
Mhm.
And, you know, and we
Yeah.
have fries today. So that's how it should be.
absolutely.
Thank you.
Thanks for indulging me.
Hey, a day rodent control.
All right, so I'm just going to make this brief. Cassidy, can you please put up the diagram? All right, so here's Washington Park. Between the playground and the basketball court is the entrance. So we placed the bait box 1 next to the basketball court, 2 next to the tennis court, bait box number 7 next to the baseball field. We have, let's see, bait box number 5 next to the playground area. We have 6 at the back, and then we have 3 and 4 to the you know, to the west if you're facing the field. And pretty much we mimicked the we just copied the same way the we used to have the bait boxes with Yankee Pest Control, just to be able to like compare data. And what we realized, let's see, let's go to page 1, the first one, 9/12. Okay, so on 9/12, we placed those bait boxes in those locations. And then we went out a week after to 9/18. And what we realized was there was a moderate activity in the first one, which is next to the basketball court. We started with 400 cubic centimeters for each one. And we ended up with 300 the first week for bait box 1. The other bait boxes, we didn't really see much activity. You know, they went down to like 350, and then we went out 2 weeks later. You know, for the bait box 1, went down to 300 cubic centimeters. We saw a considerable amount of consumption of the liquid contraceptive throughout all the bait boxes. We went out a week after that. Let's see, that was 10/3. And what we started to see was that the area around the basketball court has like the highest consumption of the liquid contraceptive. So we're wondering why that's happening. Not sure yet. Again, we still don't have enough data. This is just 5 weeks in. We will continue to monitor. And let's see, if you go to 10/9, which was 3 days ago, you know, from 400 cubic centimeters, now we have 100 cubic centimeters for bait box 1. So again, we don't have a lot of data, but you know, the 4 weeks of data that we have, we are seeing a considerable level of consumption throughout, with bait box 1 having the highest level of consumption. So it looks like that tank is going to be filled pretty soon. It's going to be refilled pretty soon, since we're down to 100 cubic centimeters. Again, the plan is to move those bait boxes around, you know, from areas with low activity, move them to areas with high activity. Again, we don't have enough data, and we'll just keep monitoring. So that's pretty much all I have for rodent control.
I love the data presentation. I
Mm.
love that.
Yeah. Everything has to do with data. You have to be able to support it with data. If not, it's gonna be it's conspiracy. Yeah, we
That's
don't
right. That's
we don't do that over here.
What's nice is that it's very quantitative, you know. I
Mm.
think the reports we were getting from Yankee Pest Control were very qualitative and, you know, hard to interpret. So,
Removing some of the subjectivity. Yeah.
Correct. Eventually, when we have enough data, we would plot out the graphs and everything to make everything easy.
Mhm.
Yeah.
Ade,
Yeah.
have the neighbors noticed anything? Have you heard anything from the neighbors surrounding the area?
No, we've been getting complaints about 87 Washington, you know, overgrown vegetation. I was there last week, and apparently it used to be owned by a mother and daughter. They both passed away, and it was abandoned for a long period of time. But somebody showed up 2 weeks ago to take ownership of it. Well, things are looking promising. He said he was going to mow the lawn and, you know, keep everything looking
I
good.
just wondered if there was a contributing factor or if they were getting impacted by the
I mean,
presence of all.
obviously, 87 Washington is a contributing factor because it's overgrown. It
Yeah.
harbors you know, rodents and rats and all those things, skunks, and it's an abandoned building as well. So yes, 87 is
is
an
it,
eyesore.
is it near the basketball court? I don't
Yes.
know. It is. Okay.
So, but yeah, things are looking better over there now. So,
Oh, good. Thank you.
yep, thank you. And in terms of, let's see, monthly report. In the month of September, we conducted 11 comprehensive food inspections, 3 food re-inspections. We issued 27 temporary event permits. We completed 3 housing complaints and 1 trash complaint. For some reason, Maven was down today, and I kept on doing the report, but it was giving me, you know, no COVID data, like every time I try to do a report. So I'm not sure what's going on. Again, those numbers are not reliable because a lot of people are not doing the
Reporting.
testing for COVID anymore. They're just using the regular test kits, you know. And I mean, people know how to deal with COVID now. They know how to handle COVID. They don't feel the need to report to the state that they have it. So even if, you know, we do have those numbers, they're still not accurate. So,
And
but
we have I know the dashboard's updated to have the info, including ED visits and admissions, but I don't think it's capturing urgent care visits. And I know that folks are really being encouraged to not go to EDs for you know, for
Correct.
respiratory. So you know, I think it'll be interesting to see how you know, what it seems like our numbers in general are going to be diluted and not reflective of
absolutely,
activity. So
absolutely.
Probably the most accurate ones are hospitalizations and deaths.
yes,
and-
that'll be yes.
and the sewer or
And the biobot. Yep.
Biobot, yeah.
And we're not dealing with the same COVID anymore. It's
No.
different. We have treatment for COVID now. You know, get vaccinated. Yeah, you know, social distancing, do all those things. People know how to handle COVID now, so it's not as
Amazing.
bad as it used to be.
Amazing.
Is the town supplying tests anymore?
So we ran out of test kits, and
Oh.
but we were lucky. You know, I got an email from the state on Friday. They were going to do a one-time courtesy of shipping out test kits, so I signed up for it, and they gave us 1,800 test kits. So they should be arriving anytime from now.
The reason I ask is I was subbing in one of the schools and one of the parents had gone to the library and they didn't have any. So I sent her to the town hall, but it was Friday, so she could. So
Well,
I thought
think
I'd ask.
she called and we gave her one.
Okay, good.
We did.
Nice.
Do we distribute some of those tests beyond town hall, right? To the library, to the Pleasant Street Center.
Correct. And
So
also,
we're-
you can order free test kits online. The Biden administration is giving out
Yeah.
5 test kits for each household, I believe.
Mm.
We have that information on the website as well.
Because it's expensive when you buy them at
Correct.
yeah. Yeah.
Yeah. So let's see, what else do we have?
While you're looking at it, I just want to celebrate for a second what you said. We know how to handle COVID now, right? We know, I mean, Kevin, did you expect to hear those words when, all those meetings? You were our predecessor before we all joined, and
I hate to say it, but yes, I did.
did you okay, well, right, but
Well, I know people very well, and I knew exactly how this was going to go from day one right to where we are today.
you did.
Yeah, actually, if you go back and look at the early tapes, you can see the prediction live.
I mean, I knew, yeah, but you
I think
weren't
I
at our
knew we'd eventually
tabletop,
get here.
so.
My other prediction was we're always going to deal with it. This is not going away, right?
absolutely.
I mean, that was very early
Pandemic.
on. Everyone was kind of on that, had that same prediction. But it is really good to see. Here's what I didn't expect. I didn't expect it this fast. That we'd be at the
Really?
point where we're saying we know how to deal with this. We know how to live with this.
Right.
I don't think I expected it this fast. So that's a great accomplishment.
It is.
It really
COVID
is.
Flu clinics are still ongoing. We had 4 clinics for senior residents, September 19th, 27th, October 4th, and October 12th. So we did the last one today. We had COVID and flu clinic for the general public on the 22nd. We have another one coming up tomorrow, and then we have one more on the 3rd. And Shaw's did agree to include the RSV vaccination as well.
Okay.
So people can get vaccinated for that as well.
Have the flu clinics been well attended?
Yes, they have.
Good.
High turnout. So we are planning on having another major one. But we don't have the date yet, but it's going to be a big one. So in terms of the health of the department, I know it's the health department, but is it a healthy health department or an unhealthy health department? But in terms of the health of the department, things are going well. Jen has been great. Cassidy has been great. We got 2 applications for the nursing position. We plan on interviewing sometime next week. Yeah, things are going well. No issues, no complaints.
Tap wood.
Good.
Yep.
Okay, anything else? Guess not.
Nope.
Okay, well,
It's such a pleasure to be part of this board and have us in this place where we are. We've made such strides in, the time that I've been on, and, I guess it just makes me so happy. And
Yeah.
thank you, Aday and Cassidy staff for
I
making
will
that.
second that one.
Carrie, you have no idea.
I have an inkling, but yes, I know.
From a long time and many meetings ago.
Yeah,
This is a great spot. I'm really
Yeah.
I'm glad you brought that up because it's really is a great spot that we're in right here.
it's just wonderful. It's really
the health
great.
department and the board, yeah.
Absolutely, the whole thing.
Yep.
Couldn't be happier.
So we have a meeting in December.
That's
Well,
Right.
not November. We're not doing November.
We are doing
Oh,
November.
we're
Oh.
doing November. I don't know about December. You know, if you decide with Jamie to, you know, have all the board members in one of those planning meetings in November to go over the data, then maybe we don't. And we might end up having a limited meeting. I don't know. We'll play it by ear. We'll see where we are at the end of next month.
Okay.
Good. And I'm gonna meet with John Lamond. He's the MRC coordinator.
Mhm.
So we just want to talk about, you know, MRC, how they can be helpful to the town of Reading. So, yeah.
So I'm going to plead ignorance. What does MRC mean?
The Medical Reserve Corp.
Yep.
Oh, okay. No, I know what that is.
Yeah, they can do all sorts of things. So that's great.
Okay, so I'm going to make a motion to adjourn. Do I have a second? Paula, second. Roll call, Carrie,
Yes.
Paula,
Please.
yes. Rick, yes. Thank you, everybody. Great
Right.
meeting.
It's good to see
you.
you all.
Thank you.
Take
Good night.
care.
Month.
Bye.
Recording stopped.